Welcome to tonight's webinar, Telehealth and Surgery During the Pandemic, Lessons Learned and Guidance for the Future. Next slide. For tonight's webinar, all attendees' lines are muted. The handout is available for download as noted in the GoToMeeting right-hand box. We request you type in your questions in the cell immediately below, and we will collect those throughout the Q&A following the presentations. Next slide. I'm Linda Barney, Chair of the American College of Surgeons General Surgery Coding and Reimbursement Committee, and I will serve as the moderator. We now have 6 months of pandemic surgical care under our belts and an opportunity to reflect on how care delivery models have changed in the era of COVID-19 and how our practices are adapting to the challenges and opportunities looking forward. We have 2 outstanding speakers this evening to share their insights and telehealth journeys from the vantage point of unique surgical practice environments. Dr. Steven Sentovich is a colorectal surgeon, clinical professor, and physician lead on clinical operations at City of Hope National Medical Center in California. Steve is a valued member of our surgical reimbursement community and serves as AMA RUC advisor for the American Society of Colorectal Surgeons. He will focus on telehealth implementation in surgical practice during the PHE. Our second speaker is Dr. Catherine Matthews, professor and fellowship director of female pelvic medicine and reconstructive pelvic surgery in the departments of Urology and Gynecology at Wake Forest Baptist Health. She serves as co-director of the Wake Forest Integrated Pelvic Health Unit and as co-author of the handout article on implementation of outpatient telemedicine program during the COVID-19 pandemic. She will speak on early learning from telehealth visits, platforms, benefits, and patient experience. We will wrap up with opportunity for Q&A for participants who have not visited the ACS COVID-19 telehealth resource page. I recommend you take a look. It can be accessed at facs.org telehealth, and the link noted below. Our health policy and advocacy staff, Lauren Foe and Vinita Majumdar, are also on the call and have done an awesome job at getting the resource pages up and running, weeding through the regulatory issues, and assisting ACS fellows as we navigate through this new frontier of telehealth for surgeons. Next slide. You can see we have a lot of great resources available, identifying the types of resources that are on the site, which we're trying to keep updated with the ever-changing atmosphere of telehealth. We've outlined changes to the Medicare rules during PHE, some comparison of the various virtual services by modality, eligible providers, and information on coding and modifiers, description of the various virtual services, HIPAA and other privacy rules, and links to private payer and vendors. So with that, we're going to go ahead and get started with Dr. Sentovich.
Thank you, Dr. Barney, and thank you for you and the American College for the opportunity to share our experience at City of Hope. For those of you who don't know, City of Hope is a comprehensive cancer center here in the Los Angeles area. It includes a 217-bed medical center and research hospital, as well as 30 network locations throughout Southern California with clinics, infusion centers, radiation therapy. As an enterprise, we do about 350,000 visits a year, and there's approximately 500 physicians and advanced practice practitioners. If we could go to the next slide. On a high level, City of Hope's response to COVID, we started out with really very limited or no telehealth use prior to March of 2020. And we're in the process of developing a televideo platform over the next 6 to 8 months. With the stay-at-home public health emergency, we accelerated our televideo platform development from about 6 months to 2 weeks. We stood up a web as well as app-based platform with our vendor Amwell that we labeled Hope Virtual, as you can see in the slide here, to enable telehealth visits, onboarding physicians. We use Epic and built the workflows to support this, as well as developed training materials and even deployed press Gainey surveys for our telehealth visits. In the next slide, we'll go into a little more detail. We can go to the next slide. So City of Hope's telehealth journey started in March with the stay-at-home order. And at that point in time, we had a wholesale clinic conversions of either maintaining an in-person appointment for patients with cancer who absolutely needed to come in versus postponing the appointment versus converting the appointment to telehealth. This time period was characterized by unfamiliar workflows for both physicians, clinic staff, and patients, as well as somewhat glitchy tech. You can see in the small diagram graph in the bottom left-hand corner that our telehealth visits by week in the first month shot up to about 1,000 per week, and then by 6 to 7 weeks we were close to 2,000 telehealth visits per week. As we move on into May and June, we began scheduling telehealth visits for both follow-ups and surveillance. We improved the workflows for both patients and physicians, particularly adding patient support, which is critical. Our tech also stabilized internally. The connectivity and device issues were worked out, as well as externally what devices were recommended for our patients. The bottom diagram in the middle section there, graph shows the percent of telehealth in our clinics, which in our community setting, which has a little more benign disease, we peaked at around 60%. In our cancer center hospital, we were at around 30%. Currently, telehealth in the community is around 30%, 32%, and at the main medical campus is around 15 to 18%. Now in August and going into the future, we're planning more virtual clinics, specialty specific indications for telehealth, serving the patients with respect to convenience and actually now their familiarity with telehealth and demand for the service. I think we really need to capitalize on telehealth and integrate it into our care of patients, both in person and with telehealth visits that can provide access, quality, efficiency, and safety for patients. The future with respect to tech for us is to embed our telehealth platform within our patient portal to make it seamless. To date, in the first 5.5 months, we've performed 33,000 telehealth visits. Next slide. There's a number of keys to our implementation of telehealth. I'm going to highlight a few of those in this slide, starting at 12 o'clock with access. One of our first initial problems was making sure that new patients had a general treatment consent that was typically done in person. And so we converted the consenting appointments to televideo as well, so that we could serve new patients with the telehealth platform. Figuring out and working through the pre-telehealth clinic workflows to ensure that the visits were successful for both the patients and the providers was also spent a significant amount of effort on and is key to the success of the telehealth program. We also had significant communications with an external and internal web pages and updated tip sheets for both providers and patients. There's significant IT involved with telehealth and build. We had Epic build for orders, appointment types, templates. We use smart phrases as well as eventually a documentation flow sheet that I'll show later. With respect to the revenue cycle, we needed to make sure we had the appropriate codes and modifiers in place. And because this was all new, we set up a compliance review of all encounters prior to billing. This was also related to the fact that payers were changing their rules almost weekly initially. We wanted to make sure we were using the most appropriate codes. I would note that currently the revenue cycle workflows are still complicated as there are payer variations with respect to coding of telehealth visits. Initially, we actually were able to use volunteers to do tech checks with patients prior to their visits to make sure they were ready to go on the platform. With respect to compliance and legal, an ongoing issue that has been a significant challenge for us is out-of-state. We do have a lot of out-of-state patients, and the rules are, quote, waived, but not waived completely. Every state has different rules. In addition, the rules have changed over time by state, as well as there can be different rules whether or not the patient is established or a new patient. So this continues to be a challenge. We have a current workflow and build out to inform providers of upcoming appointments that are out of state and the requirements that may be necessary to ensure that that appointment can take place. Finally, we'll end on MD training, which is actually where we really started. We employed multiple webinars, tip sheets that actually had to be revised multiple times because of the changes in the CMS rules, as well as we provided real-time support for physicians when they were doing these visits. Next slide. So I'm going to concentrate on a couple of virtual services. There are a number of virtual services that are available and covered by Medicare. You can see the CMS list on their website, but the ones that certainly are going to be used most frequently are the true telehealth services, which are defined by CMS as real-time two-way audio-video or televideo appointments that you can do with new patients as well as established patients using the same exact codes as in-person visits. A 95 modifier is added to these codes to designate that it is a telehealth visit. The other important virtual service for surgeons is telephone call visits, which have their own separate set of codes, these 99441 to 443 codes. Next slide. With respect to televideo visits, a little bit about documentation and coding. These visits can be either for new or established patients. They're essentially equivalent to an in-person visit, and you're using the same CPT codes, just adding that 95 modifier. And after some changes initially, they've settled on this coding mechanism of coding on the basis of either time or medical decision making as shown in this table. The times are shown on the left-hand side. The medical decision making is what we are familiar with respect to the number and complexity of problems, the amount and complexity of data to review, as well as the risk of complications. The only proviso that may be slightly different compared to our understanding of in-person visits is that time is defined as the total time the day of the visit. So this does include the video chat time as well as any medical record review, any documentation, orders, and care coordination. Next slide. Telephone call visits are a bit different. There's criteria for telephone call visits and special codes for telephone call visits. These are typically patient initiated with respect to the patient desiring a phone call in lieu of an in-person visit or does not want to come in. It can be done for both new and established patients, and it needs to be there needs to be no prior E&M service in the past 7 days, and no face-to-face visit in the next 24 hours or next available. With respect to coding, it's a little simpler. It's just the straight exact talk time of the telephone call visit. You can see the 3 codes 99441 through 443 shown in the box and the associated times with those codes. These were have relatively low reimbursement, but in the public health emergency, these telephone call visits are converted by CMS on the back end to level 2 to 4 established patient visits corresponding to the 3 levels. There is no crosswalk to a level 5 established visit. Of course, new patients done by telephone will also crosswalk to these level 2 to 4 established patient codes. And I would want you to know that there are some payers who consider audio only, so a telephone call, the same as televideo. And for these payers, you should actually use the in-person new and established visit codes with the 95 modifier. Next slide. We provided our surgeons with a virtual checklist to remind them of the things that are potentially different with a virtual visit in terms of discussing the risks and benefits of telemedicine and obtaining verbal consent, asking for the names and locations of the participants, verifying the patient's preferred pharmacy, if that hasn't already been done by the clinic staff. Certainly if they're documenting televideo visits by time, we wanted to always remind them that it's the total time spent, the video time, the record review, documentation, orders, and care coordination. As well as for telephone call visits, it's just simply the phone call talk time. These visits are different, so there is a skill set to facilitate dialogue, allow patient inquiry, understand and mitigate some of the limitations of a televideo visit, provided them education regarding these visits prior to them starting their telehealth visit scheduling. Next slide. With respect to the documentation requirements, we initially used a smart phrase, but then replaced that with a telemedicine documentation flow sheet shown here, where the surgeon or physician could choose the visit type, whether they obtained the verbal consent, MD location, patient location, who else was present during the visit, the discussion diagnosis, as well as the basis of coding, whether it be medical decision-making or time. This facilitated completion of all the required elements is attached to the note and was easy for our compliance team to audit these when it was time-based coding. Next slide. With respect to televideo and telephone indications and recommendations, I think that we really, as surgeons, need to capitalize on telehealth in terms of its ability to improve access, quality, and efficiency. And there's a whole host of potentially appropriate virtual visits related to a lot of visits that are primarily discussion-based, where no physical examination is needed. The patient prefers a video visit, as well as a number of other important ways to integrate telehealth into your practice. I think for televideo visits, this is the only question is it any visit is possible, so is a virtual visit medically appropriate? In some instances, it may not be, but many others, it can be. For telephone visits, really the best use is the established patients level 2 through 4. If it's a new patient or a level 5 established visit, it's probably better done by televideo or in person. Next slide. So where are we going in the future of telehealth? I think with respect to platforms, they'll all be HIPAA compliant in the future, and portal and EHR integrated with on-demand access without needing an app or a password or other ways that can kind of thwart patients as well as physicians' progress with this technology. I think it'll be an option for any visit, but clinical indications will certainly develop by practice type. I think the telehealth appointment will become a standard appointment with well-established workflows, both in the clinic as well as on the revenue cycle side.
Great, thanks, Dr. Sentovich.
Thank you. I've just two more comments since the slides jumped. So in conclusion, with respect to healthcare environment and culture, I think that advocacy is very important going on into the future, since really all of telehealth is temporary at this point in time. I think that also involved in that would be patient-centered out-of-state rules. I see expanded remote monitoring, hospital at home, and it really completely enhanced telehealth visits in our future. And in terms of the vision of bringing care to the patient, I see a digitally engaged patient in the center of an integrated digital care network. And so with that, I'll conclude and turn over the presentation to Dr. Matthews, who will share her experience.
Thanks so much, Steve. Sorry, did you need to, was that jumping in too soon? I'm not really sure. It's difficult to coordinate this from across the country, isn't it?
No, you're doing great. I was just going to remind folks to, if they have questions, to please write them in the chat box, and we'll address after both speakers have completed their talks. Thank you.
So Steve did a beautiful job describing from a systems approach how one can take a whole institution from an in-person to a telemedicine platform. And I'm all about giving you some practical advice from being in the trenches, how you as an individual practitioner can make this happen for your practice and your patients. Next slide. So, you know, I think that this is a very apt question that is all over the media. Is telemedicine here to stay? Next slide. And what we've learned from this is that patients such as this one don't need to come to the office unless it's really necessary. And COVID, while it's brought many lemons, has really provided lemonade to my clinic, in that I'm able to offer an alternative to people who don't actually benefit from coming into the clinic. And we've learned that it's very patient-centered to offer this as an alternative, but also you can imagine how a patient such as the one demonstrated here can blow up a clinic that's got 50 people scheduled, because she may have 40 medications and it's going to take her 15 minutes to walk down the hallway, and that can be very problematic in terms of your nursing staff if it's not absolutely necessary for her care. Next slide. So when we were faced with, you know, the reality in a matter of 2 days of going from seeing a very full clinic of patients with urogynecologic problems and other urology issues to having to, in a minute, turn on a dime to see these people virtually, we put together a toolkit because we didn't find it easy, and we thought that maybe our experience would be helpful to others. This was published in the August issue of Journal of American College of Surgeons, and my fellow Whitney Smith was really integral to making this project happen. And next slide, the toolkit really details everything that we did within our clinical center to make this happen. And it started with figuring out for ourselves how we would make this work. And we started with using our Epic infrastructure and realized very quickly that it was incredibly onerous to use this HIPAA compliant platform for telemedicine, because they didn't actually have the appropriate applications built into Epic at this time to make it happen. So if you had a computer that you were already logged into MyChart, you could connect. There were connection issues. It took a lot of internet speed and bandwidth to make that happen. So we very quickly recognized from the physician perspective that we were going to use an alternative platform, Doximity. Now, Doximity is a physician or provider-centered platform that you have to join, and then they have to invite you to be have video capabilities. So not everyone could join this, but as a physician, you have full capabilities of joining Doximity. And that was the platform that we found was the most accessible to patients, regardless of the type of hardware that they had at home. Patient education was a big part of this. So people didn't know about it. They had to be educated about how they were going to log on, how the visit was going to work, how it was going to be very similar to an in-person experience, where they were going to get a phone call from the nurse that would go through their medications, their history, They would enter all of that information into the EMR, much like they would if they were being seen in person. So this piece is what required the 2-to-1 ratio of nurses to physicians to actually make this happen. In terms of the hardware, one recognizes also that patients that are low income and that don't have good access to internet are very much discriminated against in terms of video visits. Fortunately, with the Doximity platform, you don't need very much in the way of hardware on a smartphone device. But we also recognized that if you just had a telephone, that we would have to very quickly abandon the hope of having video connectivity with somebody who didn't have access to internet, and that we learned quickly that you could waste 15 minutes of a 30-minute scheduled visit trying to connect with people, and it was better to bail early and just do it by telephone. Steve has done a nice job of going through the coding and billing integration, but this is all laid out in the handwork. This IT support business is big. If your institution is requiring that you use only HIPAA-protected platforms, which now have been waived, of course, by CMS, but if your institution is requiring this, you have to recognize that things like WebEx and Epic can have major problems with IT support in terms of having enough bandwidth. So the audiovisual platforms, again, that we settled on, that we use almost exclusively now is Doximity. And of course, this links with the existing EMR infrastructure so that you can access the patient record and include instructions for the patients that they access via things like MyChart. But all of the direct communication happens on platforms, as I said, most commonly Doximity. Some people do prefer to use FaceTime if they have an Apple device, but of course not everyone has that. And then finally, a big piece of this was figuring out who needed a helper. I find myself needing helpers in the clinic when I'm trying to navigate through new telemedicine or new IT things. And I find that the younger the helper is, the more help they can be for all these IT issues. And so we have universally found that people over age 70, we invite them to invite a family member to help them with the telemedicine visit, to get them hooked in and make sure that all the audio visuals are working, and that's been very helpful. Next slide. So, Steve showed you what they use at their institution. You need to have something like this that is populated in every single telemedicine encounter for compliance. So you can use this from the toolkit. It has the appropriate language. And you again can see here that it gives you the opportunity to select if it was just video or just audio. Next slide. So what did we learn? What can you learn from the pain that I've endured to make this easy for you moving forward? We talked about the platform, that we really essentially abandoned the use of things like the Epic approved platform. It requires 2 separate applications for people to download. It's complicated even for someone with knowledge about how this works. And so, I think that anyone starting out, unless you're pretty savvy with how your technology works and the patients that you're treating are very savvy, I would discourage the use of these HIPAA protected platforms right now. Now, as Steve mentioned, moving forward, that would obviously be the way that we would hopefully go, that things would really improve. But right now, this is a problem. What do you need for nursing support? This is not something where you can throw physicians to the wolves and say, you go and do your telemedicine visits by yourself. We've actually found that they need a little bit more nursing support because of the time taken for patient education and the time taken to connect with the patient, go through all of the medications, go through everything that they need to enter. And so you need really one to work today's schedule, because you can imagine if someone is difficult to reach, if someone is taking longer to connect and get all that information entered, if your nurse is just doing this 30 minutes ahead of the next patient, all of a sudden your whole schedule can get thrown on its head. So we have our nurses do this one whole day ahead, where they get all this information from the patients on the schedule. They have everything organized in terms of education, so that you then have a person helping you the day of, but somebody who's working the next day's schedule. Patients need a lot of instruction regarding this process, and I would say that you would probably need to bank on your nurse spending at least 30 minutes with every patient to get this all figured out. And once someone is an established patient, it's a lot easier, but for new patients, if you recognize that this 2-to-1 ratio is necessary and to bank on 30 minutes a patient for your nurses. We really do believe that the exact same functions that happen in person always happen with the telemedicine visit. And so once we have checked the patient out, our front desk personnel is waiting to receive the same message that they would have received from us via the EMR for what needs to be done in follow-up. And you will see from our early learnings that I have really determined that the efficiency of the follow-up visit is dramatically helped by initially doing a telemedicine visit, so we can direct our nursing staff as to what is going to be needed when someone actually comes into the clinic in person. Like they're going to need a flow and a residual volume, like they're going to need a chest x-ray and a basic metabolic done in the lab before they actually come up to see you, so that you can direct and quarterback the rest of the services that the person will need when they actually do make the trip into the clinic. What about family support? I mentioned already that our absolute experience is that people over 70, I hear I say 65, but really 70 seem to be the cutoff, where we really would encourage them to have a family member be present on the day of the visit. The other thing I found to be a fascinating issue is that while one would assume that people would be more flexible waiting in a virtual waiting room for your telemedicine visit, it turns out that people are a lot less flexible. Somehow when they make the commitment to drive downtown to see you, they've parked, they're sitting in the waiting room, while they may be irritated if you're running half an hour late, they don't seem to be as put out as if they have left their office in anticipation of getting a phone call and they don't get it. So they get very frustrated about that. So you have to be very on time for these visits. They're not nearly as flexible as in person. Next slide. Hybrid clinics of telephone and in-person do not work. And I say this again because how often are we walking into a patient's room at exactly the time the schedule has said? It's very infrequent that we're that punctual. And the telemedicine visits, patients are going to be expecting the phone call at the time that it's scheduled. And so oftentimes when you've got a person expecting a phone call at 9:30 on the dot, you're still in someone else's room. You don't even realize you're going to pick up the next chart. You don't realize that it's a telemedicine visit. So don't schedule hybrid clinics. Do your telemedicine visits either as a dedicated template or have dedicated visits at the beginning or at the end of your clinic sessions. You will quickly recognize that if you open up a full day of new patient telemedicine visits, that you can schedule in any workday 16 new patient visits. Now, I don't know if you're like me, but normally if I was seeing new patients on a regular clinic day, I would have a maximum of 8. Because again, those new patients, if you have some medically complex people that sort of blow up your clinic, so to speak, you really can't have a lot more than that. Whereas in telemedicine, if your nurses have done the work the day before, you can very predictably fit in 16 new patients. This was essential for ongoing access to care during COVID and moving forward when things were very backed up. And we found that our OR schedule continued to flow very smoothly because of the opportunity of bringing in new patients. And so I think that this is important to recognize that if you're willing to commit to telemedicine, that you can drastically increase your exposure for new patients. So I have a new model moving forward. Once everything in North Carolina opened back up, we didn't abandon telemedicine as a platform. I instead moved to having at one location, seeing people in person, also offering some telemedicine visits at the beginning and the end of those templates. But in a clinic that I was going to off-site that was 45 minutes away from where I live, I'm going there now every other week. So on the weeks that I don't physically drive there, I do a full new patient templated clinic for 16 new patients. And then the following week, I do all the in-person visits for only established patients, return patient visits. those visits are dramatically more efficient because I've determined exactly what needs to be done. The patients have already got all of their EMR information filled out. And so our nursing staff is able to see, we're able to process a much higher number of return visits on those days, as opposed to the people that I could have seen on the phone for return visits. I will tell you that if you schedule more than 30 return patient visits in a day, it gets to be extremely overwhelming because sometimes people are difficult to connect with via video. It's like there's some delay and then your whole day, it's difficult to catch up. So I think that these are the limits of what I would recommend in terms of creating templates. So the thing that I've found to be helpful also is when I do a new patient telemedicine visit, I can alert myself, this person is super complicated. They're going to need more than a 15-minute return visit. They're going to need a 30-minute return slot because of all the issues that we have to deal with. I can determine exactly what imaging studies need to happen, any other ancillary testing that needs to happen. And importantly, you can generally figure out, based on an initial phone conversation, if a person is going to need surgery. And then you can figure out also, before you've actually seen them in person, what would be the time frame of that surgery? Is this somebody that you need to bring in the next week for an overbook because you actually want to do surgery on them in 2 weeks when you have an opening? Or is this someone that needs to have surgery next January and you only need to bring them in December? So I really have found that this predetermination for OR scheduling is very, very helpful from the surgical standpoint. Next slide. Which visits do I find to be particularly beneficial for telemedicine? Well, all the preoperative visits. So you have an established diagnosis. You know exactly what you're planning to do. This is about counseling, about reviewing ERAS protocols, about getting your patient prepared and getting them informed in terms of the consent process. So we do all of this by telemedicine. No one is coming into the separate visit with us to go through a preoperative visit that, of course, is part of your global reimbursement. I find interval postoperative visits to be very, very helpful. The person that you want to check on how things going with bowel, voiding function, determining pain. So I find that instead of making these people come into the clinic, again, that you're not going to be reimbursed for these visits anyway, much more helpful to phone them and check in by video if necessary. Of course, all those people at risk for COVID, much better to find out what is the medical problem to then determine, again, how can you limit the number of in-person visits for them with imaging. Here I find that, again, new consultations for things that are an established diagnosis by either an internal medicine physician, a family physician, someone who's referring the patient to you for a diagnosis. These are particularly well suited for that new patient telemedicine visit. Let me give you a quick example. So I'm a urogynecologist. I see someone for pelvic organ prolapse. You might well say, how in the world could you possibly figure this out, a vaginal problem on the phone? Well, it's amazing asking the patient about their bulge symptoms, their urinary symptoms, their bowel symptoms, and then importantly, what is their goal? Do they want to have surgery? Do they not want to have surgery? If they tell me, I'm for sure I want to have surgery, the intricacies of my pelvic examination in terms of exactly what's there is probably not going to change my general thinking about would they be better served with a transvaginal approach, with a laparoscopic approach, with mesh, without mesh. I can figure all this out by doing a good risk assessment and determining their symptoms. So again, in any general surgery realm, there are all kinds of different diseases that have already been provided a diagnosis and you're seeing them for the surgical care. These are, again, well suited to telemedicine. People who live remote from your facility, we, before COVID, had good information that these people are very well served by telemedicine. Steve brought up the very valid point that unfortunately out-of-state visits can be complicated for people that are covered by Medicare in that state because there can be state-specific rules that change. So for example, in North Carolina, the rules are different for Virginia versus West Virginia versus Tennessee versus South Carolina. So depending on who's calling in from those different states, you may need to bring them in person, which is very unfortunate because, of course, those people might be better served by a telemedicine visit. And then, people with mobility impairment, all those people who are in wheelchairs with canes, it's amazing what you can actually get done by a very carefully directed history and review of their subjective symptoms. Next slide. What have I found? I had published this, funnily enough, before COVID, because I was intrigued as to the necessity of doing pelvic examinations for certain diagnoses. And I just showed this to you as an example that, for example, recurrent urinary tract infections, we used to do a pelvic examination universally on these people, and we've determined that it doesn't actually significantly change. And I would imagine that within your practice, there are a whole host of diagnoses that potentially are better served by an imaging study, or that someone else has examined them and you don't need to repeat the exam. So I just challenge you to say, what other diagnoses are you currently seeing out of habit but haven't really been determined to be necessary to see them in person? Next slide. What have I found does not work well by telemedicine? Pain. I must say that people who are calling or who are coming to see you for pain seem to benefit from a careful and directed physical examination. And I've not found the ability to discriminate from a pain perspective exactly what's going on the phone. I do think in general, these patients have a higher need for in-person connectivity. And so I would not recommend this as a diagnosis for a new patient telemedicine. People with acute infectious issues where you may be concerned about the potential for a systemic infection, where you want to lay eyes on a person. I found that acute infection, if it's something simple like a urinary tract infection, that may well be served well by telemedicine. But, if you're concerned about someone calling in with, acute cholecystitis, for example, usually you may want to examine them. Postoperative wound evaluation, I'm also nervous about because I feel that our ability to discriminate what's going on without looking at a wound initially is impaired. Now, of course, there are developing applications for different disease states, wounds being one of them, but the initial examination to investigate a wound is better done in person. And then, of course, acute injuries. So someone breaks their arm, falls down, and is worried about a broken arm versus a sprain. Very difficult to figure that out over the phone. So acute injuries, I think, are better seen in person. Next slide. We have found, in review of our own data, that we found that 25% of patients were able to immediately book surgery based on just their initial telemedicine visits. Of all the telemedicine visits we did, we had a 4-to-1 turnover into a direct surgical booking. And 30% of new visits were booked for a subsequent office procedure. So this demonstrates to you, I think, the utility from a surgical perspective of being able to get people in to the system much more effectively than if they were waiting for a new patient visit that you may only have open on your schedule 6 weeks from now. And the irony is that oftentimes we may have an opening on a surgery schedule that came about because of a cancellation because of a COVID patient, or a cancellation because someone got sick from something else, and you have an opening on your surgery schedule, but you didn't have an opening for a new patient visit. And this telemedicine access gives you the opportunity to see people quickly to be able to then fill your surgery schedule. I don't think any of us can really ignore the time and money savings for patients. Someone who could step out of their office at work and conduct a telemedicine visit with you, as opposed to spending 3 hours with both themselves and their family member to drive to your office, park, come in, have the visit, leave, drive back home. 3 hours is sort of the minimum. If you live in a big city like LA, it's probably a lot longer than that. And I really want to point to the greater efficiencies of the follow-up visit. Knowing your nurses, knowing what your plan is for that patient that you've typed into your note from the telemedicine encounter is very much a roadmap for how to make the subsequent visit in person a whole lot smoother. Next slide. There are negative effects of telemedicine that we need to take into account. I've already talked about the challenge of the hybrid clinic. The office staff utilization can be high. Your bricks and mortar utilization is much lower, but your staff utilization is higher. Do you think there's a significant issue potentially with provider burnout from screen interaction? We miss the human contact with people. It can be exhausting to connect with people, try to have energy for the encounter when you don't have the pheromones being communicated with people directly in the office. Down the road, we don't know exactly what's going to happen to compensation. Right now, the CMS rules have been extended, but it's not something that's permanently legislated at this time. And the final thing I want to bring up is, there is the opportunity for somebody to misrepresent themselves as being an expert and, providing telemedicine for this and such condition. And so I think we have to be vigilant about the quality and competency of a virtual provider. So that may be an issue moving forward for patients, trying to discriminate who exactly is this person that's providing this care to me. Next slide. I must say that the patients have loved this. I've not had a single person complain to me other than they were not appropriately counseled about the mechanism of the visit, but I've not had someone say this was a waste of my time, I'm frustrated, I just wanted to see you in person. People usually have the opposite reaction when they say, my goodness, I can't believe we were able to figure all this out without you actually having to see me. So, we've certainly had people express appreciation for not just the safety aspect and the convenience, but the dramatic time savings for them. So I'd like to open it up to Dr. Barney to direct any questions that we might have for Steve and myself. And thanks so much, everyone, for joining us this evening. And thank you so much, Lauren, and the people at the office at APS for everything you've done to help us organize this.
Thank you. Dr. Sentovich, can you estimate the percentage shift between telehealth and face-to-face encounters from early on to now when elective surgery is back up and running?
So for us, the Department of Surgery in general had a higher rate of telehealth than some of the other departments, given the nature of our work. And so our telehealth visits went up to around 40 or 50%, and then they've leveled off. The percent of telehealth is leveled off depending on the particular service. So our liver surgeons don't see much telehealth, but certainly our urologists, myself as a colorectal surgeon, and our thoracic surgeons do quite a bit of telehealth. So it varies by specialty, but we're coming around the 25 to 40% range for our surgical subspecialties.
For either of you, how did you see patients who had their imaging outside of your medical system? Is there a way to receive electronically?
So we do have some integrated radiologic centers that we can access those films via Epic, which we use Epic for our EMR. Others would mail in discs that were uploaded by staff into our system. So those are the two main ways.
There's actually a separate category for review of images as a virtual visit code. So just to let you know that you don't have to review outside films without being reimbursed for that.
What about utilization of qualified healthcare providers and trainees at your institution and your telehealth program?
Yeah, I thank you so much for bringing up that beautiful question, because I struggled with that. Like, how was I going to get my medical how would I engage my medical students in this? And just like so I've figured out that I would have, if I had a student with me, I would have them interview the next patient. Like if I was at 10 o'clock, I'm doing the 10 o'clock visit, I'd have them phone the 10:30 patient and introduce them as a student working with me, that they were going to elicit the history. So at the end of and say, Dr. Matthews will be, connecting at 10:35, so I have 5 minutes to present the patient, to me. So I would listen to their formal presentation from 10:30 to 10:35, and then we together would phone the patient. I would introduce the student, and then we would, I would just confirm the history and then go through the counseling. So you're able to do it if you, engage them to be able to independently assess the next patient, and the students really seem to benefit from that. In terms of your advanced practice providers, you would have them have their own schedule, just like you would otherwise. They're covered by the same codes that they would be covered in person.
And the joint visits could happen both via telephone or televideo. You can add participants to televideo on many platforms.
Are either of you using multiple care providers at the same time? Steve, like medical oncology, interstomal therapy, folks like that at the same encounter?
We are just beginning that journey. We have a couple of physicians in our practice that are very interested in getting multidisciplinary clinics started. It does, something like that does take some coordination of schedules. And so hopefully we'll have this going soon, in the next month or so.
Can you give an overview of the platforms available and why each of you chose the ones you are using at your institution, and who were the decision makers?
Yeah, so at our institute, so I think that from an institutional perspective, they want you to use the official line is they want you to use a HIPAA protected platform, right? That's the official thing that people will tell you. But CMS recognized very early on that was not going to be possible at this point. So they waived the rules about HIPAA protected platforms. So we, as I said early on in my presentation, that we were frustrated by Epic. We were frustrated by the Citrix, the WebEx. That was a institutional protected WebEx thing. And so we went to Doximity, and we've used that in 98% of our visits as our platform of choice.
We had already selected a vendor, and we're doing just a very slight few telehealth visits prior to COVID. And the team, our strategic team, had selected the vendor in terms of who was involved in that, along with clinician leaders. The platform we chose was the Amwell platform, and then we basically had to rapidly accelerate our development of that platform when COVID hit. It wasn't at scale at the time that we started COVID. But I agree with all the comments that Dr. Matthews made about the platform in her presentation, that there's certainly a lot of hiccups in things initially, and the standard, have it slick and integrated in your EHR or into Epic wasn't possible. At this morning's Epic user group meeting, they announced that their text app that could be outside of MyChart will be available sometime this fall, so that then you would be able to text a patient outside of MyChart, not have that complicated workflow that Dr. Matthews was referring to interact with your patients right within Epic. So the development is happening on all levels, both in our clinical practices as well as on the tech side.
I will say that, the platform that, like, how you're going to connect the person so you can hear them and see them. So we use Doximity for that, and then we really encourage everyone to sign up for the EMR so that they can access the patient instructions. So that's a big important piece of this, right? That they get the same written instructions that they would have gotten if they saw you in person. They can read the whole note. And so there are nice features now that, like, if someone's not signed up for something like My Chart, which is the Epic, personalized portal, the patient portal, you can send them an email within your note to make them sign up. So you're like, okay, I see that you've not signed up. I'm sending you the link right now to your email, and I've included all these instructions from our visit today. So, even if you're not connecting via My Chart, it gives you an avenue to get them plugged in with that, which is a very important thing. That's it's really improved our compliance with that quality metric, which is to get people hooked up with My Chart.
On balance, is telemedicine good or bad with regards to patients with limited resources and access?
Yeah, I live in Western North Carolina, so there's a lot of patients here who are low income and, they are economically challenged. And I've found that this is, if you're willing, I've been willing to sacrifice reimbursement for video visits to do telephone visits, and I found that that's been a good equalizer. To have somebody who can't afford, who doesn't have a car, who's trying to get a bus to your clinic, I always feel tragic for those patients when I really feel like they didn't need to be seen in person. So I found that if you're willing to compromise and do phone visits, which now are not badly reimbursed, I think it's very much helpful for economically challenged people.
I would agree completely with all those statements. I mean, obviously, a lot of patients have cell phones now, and so the visits can take place, but the travel is more significant for a lot of patients. And so the telehealth can be an enabler in that sense.
What would be the most useful piece of advice that you would give to a surgeon just starting to use telehealth?
Read the toolkit. It's not that difficult. I mean, you can do it pretty easily. Just get a nurse on board, read the toolkit. It all is outlined. It'll take you an hour to figure it out, and you can open it up and download Doximity, and you're all set to go.
I think I agree with that. I think that Dr. Matthews also emphasized the importance of the patient prep and the patient side of it, and I think that's key, so that there's a clinic workflow with the nurses, and I think she very appropriately talked about the resources necessary with respect to nursing staff and making sure that the patient is ready to have that telehealth visit that they are often unfamiliar with at this point, but hopefully won't be in the near future.
Dr. Matthews and Dr. Sentovich, this has been an absolutely wonderful presentation. I've spent some time with the toolkit already, and I'm all loaded for bear to go back to my office and get another try at trying to implement it in a low resource setting. For the attendees, the program was recorded, and it will be posted on the website and sent out on email. So we want to thank everyone for their patience and participation, and good luck with telehealth. Thanks, everyone.
Good night.